Welcome you all. Good evening and welcome to the college webinar. Today's present is on master examiners. I may say really master examiners, Madhusudan Upadya and Sachin, and both are known to you very well. Well, Madhu is with the Kasturba Medical College in Mangalore, and Sachin with one of the best corporate hospitals of Kerala at Ernakulam. And they'll be discussing a case, and we'll be interacting, or I may say interrogating, the postgraduate students who are volunteering today to present the case. And they may be asking, as they do in an examination. And once their answering is over, the moderators will streamline you with what additional things you may have to present.
Thank you very much, sir. Good evening. Thank you very much for the introduction of us and the topic. It's a great initiative by Indian College of Anesthesiologists to have started with the case discussions. And as it should be the practice, we are starting off with two simple cases, normal pregnancy and bronchial asthma. I take the opportunity to welcome Sachin and then also two presenters, Vignesh for the long case, the normal pregnancy. Vignesh is third year JR from Government Medical College, Chandigarh, and Vaibhavi is from, she would be discussing the bronchial asthma case with us. She is from BJ Medical College, Ahmedabad. Yeah, whoever is on the other side, long cases generally all over would have about 40 minutes. Whether you are doing national board or you're doing MD anesthesia, it's about anywhere between 30 to 40 minutes would be given for a long case. It's always better that you people are crisp while you answer and to the point, and also make sure that if you don't know the answer, you just pass it so that the examiners don't feel that their time is being wasted and they can shoot more questions at you so that you can get more percentage of questions answered. All right. We will have a discussion after this 40 minutes of presentation. If anybody has any doubts, can put it up in the chat box, and we will take up the questions and try to give you the answers. All right. Can we start?
Good evening, sir. Respected dignitaries. I'm here to present a case of a 29-year-old female, primary gravida, in the post period of gestation of 39 plus 2 weeks. She presented to the hospital for elective cesarean section. She had her last menstrual period on 19th of April 2022. She's a booked and immunized case. She works at an IT company. The patient has presented to the hospital for elective cesarean section as the doctors have informed her that the fetus is not in a normal position. The patient has no present complaint.
When you talk about the LMP, it's always better to put up the EDD also at the same place, just like an obstetric case. Okay.
And the history of present pregnancy. In the first trimester, the conception was spontaneous. The pregnancy was confirmed after 45 days of amenorrhea using a urine pregnancy test. No history such of any drug or alcohol intake, and no history of any rash, fever, or bleeding per vagina. The patient did, however, give a history of taking folic acid tablets. In second trimester, the patient has received a tetanus dose of tetanus toxoid dose of vaccine, one dose at the 6th week of pregnancy, and from then on, the patient has also consumed iron and calcium supplementations regularly. The patient did not give any history of excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision, or epigastric pain in the second trimester. The patient gave a history that she was screened for sugar levels, maybe for gestational diabetes mellitus, but she was informed that the reports were within normal limits, but there were no records available with the patient at present. In third trimester, the patient presently has a history of swelling of both feet on prolonged standing, and this is relieved after rest and on lying down. It does not hinder her day-to-day activities and is not associated with any pain. The patient does not have any complaints of excessive weight gain, decreased urine output, headache, blurring of vision, or epigastric pain. And there is no history suggestive of any giddiness or loss of consciousness when the patient tries to lie flat on the bed. There is also no history of bleeding, leaking, or discharge per vagina. The patient also does not have any complaints of pain per abdomen, nausea, vomiting, or any history suggestive of heartburn. The patient.
Why did you get the history of no excessive weight gain, decreased urine output, no headache, no blurring of vision?
Sir, these histories they help me to rule out any history as to of preeclampsia and hypertensive disorders of pregnancy, sir.
Okay.
And yes, sir.
When do they appear, basically?
Sir, hypertensive disorders, preeclampsia per se can arise in the second trimester itself, sir. That is why I asked for the same history before also, and I'm just reconfirming whether
week-wise.
Sir, 20. It can start from the late 20th week of gestation, and
that's 29 weeks.
Yes, sir.
That is 29 weeks.
Yes, sir.
No, it can be anywhere beyond 20 weeks. 24 weeks is the common answer. Yeah.
Yes.
And did she have hyperemesis gravidarum? Does it have any bearing on your anesthetic?
Sir, in the first trimester, she did not give any history of excessive vomiting. As far as anesthetic implications are concerned, if I am dealing with the first trimester patient for non-obstetric surgery, then I would look for any signs of hypovolemia and etc. Sir.
Okay, sure. Go
on. The patient presently has no history of cough, fever, nasal discharge, or breathlessness. As far as past history of the patient is concerned, patient is not a known case of diabetes mellitus, hypertension, bronchial asthma, any thyroid disorders, no history of any seizures or coronary artery disease, and no history of any COVID-19 in the past. No history of any intake of any anti-tubercular medications or exposure to tuberculosis through family members, and no history of any bleeding diastasis. No history of any long-term medications or hospital admissions in the past. I'm sorry, that is the past. The patient had no history of any blood transfusions or surgeries in the past. Personal history, the patient has presently has normal sleep and appetite, and no history of, again, there is no history of any excessive weight gain, no history of any addictions, tobacco chewing, smoking, or alcohol intake. She consumes a mixed diet, and she does not have any bowel or bladder disturbances. Menstrual history, the patient attained menarche at 14 years of age. The patient is having regular cycles once in 30 days, lasting for 4 days with moderate flow and not associated with any clots or dysmenorrhea. Family history, no history suggestive of any diabetes mellitus, hypertension, coronary artery disease, or tuberculosis, any of the family members.
You should also get the history of obstetric history in the family too, including the twin pregnancies, hypertensive disorders, gestational diabetes. They all run in the families, right? And
yes,
the twin pregnancies. That should be asked in the history when you talk about the family history. Okay.
Okay.
And one thing, Vignesh, you said there is no breathlessness.
Yes, sir.
Do you normally see dyspnea towards the end of pregnancy?
Yes, sir. Due to it can be normal at the late third trimester, sir, due to the enlargement of the gravid uterus, and it can compress on the diaphragm. And it can elevate the diaphragm, and that can cause breathlessness.
So I was a little surprised when you said there is no breathlessness. That's why. Anyway, continue, carry on.
The patient, on general examination, the patient is conscious, oriented to time, place, and person, moderately built, with a weight of 68 kgs and a BMI of 24.9 kg per meter square. No signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or bilateral pitting pedal edema at present. Vital signs: the pulse rate was found to be 95 beats per minute, regular and rhythm.
When you talk about the weight, it's always better, prudent that you also mention about the preconception weight of the patient. You kept talking about excessive weight gain, and if you just talk about the BMI now, that's not enough. You should also know about the weight gain. How much of the weight the patient can gain during pregnancy?
Sir, the patient can gain anywhere between 12 to 18 kgs in the full duration of pregnancy.
What contributes maximum to the weight?
Sir, the gravid uterus and the fetus will come to.
Obviously, fetus is a foreign body which grows, right?
Yes, sir.
Even if you assume that it's about 3.5 kilos, then the remaining 8 kilos?
Sir, it is contributed by the placenta, the increased uterine blood flow, the increased blood volume, increased fat deposition due to
exactly. The weight contributed by the fetus is not much. It's about 25 to 30%. The rest is all the weight gained elsewhere.
Yes.
Okay. Yeah.
Sir,
Carry on.
vital signs, sir. Pulse is 95 beats per minute, regular rhythm, good volume, normal in character. No radial, no radiofemoral delay was noted.
That heart rate is acceptable to you, 95 beats per minute.
Sir, in a normal patient, I would not accept this particular heart rate. It comes under the upper limit of the.
It's immaterial whether you accept it or not. If the patient presents with 95, it has to be 95. Okay. Here, is it all right to have 95?
Sir, in pregnancy, there is bound to be 15 to 20% increase in heart rate, sir.
Yeah.
So we can accept this particular.
Okay. What are the cardiovascular changes in pregnancy?
So
be brief.
Yes, so the cardiac output, the cardiac output increases due to an increase in stroke volume and heart rate, sir. There is
that's it.
Sir, the apical impulse of the heart is shifted cephalad and towards lateral away from the midline. And sir, we can hear on auscultation we might be able to hear flow murmurs like ejection systolic murmur, and we can hear a wide split of the mitral and the tricuspid S1 sounds, sir.
Okay.
Additionally, sir, the ECG may show left axis deviation due to left ventricular hypertrophy, and there can also be T wave changes, including T wave inversion, also may occur in pregnancies.
Morphologically,
sir,
when you do an echo, what can you find? What differences?
Sir, there will be left ventricular hypertrophy, sir.
That's it. Anything else?
Sir, I'm not aware of any.
Okay, carry on.
Uh,
Cardiovascular, I say. There are vascular changes.
Sir, there are capillary dilatations can occur at the airway, so that can cause edema and friable mucosal edema. This can have implications in airway management of the patients.
That's okay. Something else better. What happens to the SVR?
Sir, stroke, systemic vascular resistance will reduce in pregnancy, sir. There can be 10 to 15% reduction in systemic vascular resistance. And
yeah, when you are asked about the cardiovascular changes, you should talk about the heart rate, which increases by about 20 to 30%, stroke volume, which increases by about 20 to 50%, cardiac output goes up by about 30 to 50%. This is what you write in your exams, right? Theory paper. Same should be blurted out when you are asked about this. What happens to the contractility?
Sir, cardiac contractility will be increased, sir.
Why is it important to you, the cardiovascular changes?
Sir, there is increased metabolic demand and oxygen consumption in pregnancy. So, to compensate for that, the patient should have good cardiac remodeling to compensate for the increased demand, sir. And additionally, the patient is not only for the functioning is not only for the mother, but she is also functioning for the fetus as well as the placenta, sir.
Exactly. The fetal circulation is more important than the maternal circulation. And when you anesthetize, if at all there is any fall in the blood pressure, basically we talk about zero tolerance for hypotension in pregnancy or when the patient comes for the sections, right? Or normal delivery. The hemodynamically, the patient has to maintain the blood pressure throughout. All right. Yeah, that's why your induction is very important when you try to give general anesthesia or regional anesthesia for C-section. Zero tolerance for hypotension. Remember that. Yeah.
Okay. What are the changes in blood that will facilitate this kind of protection to the mother and the baby?
Sir, in hematologically speaking, there will be an increase in plasma volume by about 40%, and there will be an increase in RBC mass also, sir. But the increase in RBC mass is a little disproportionate to the increase in plasma volume. The increase in plasma volume is
yeah, right. What you said is right.
Yes, sir. There will be about 30% increase in RBC mass, but about 40 to 50% increase in plasma. This will cause a physiologically the patient might be anemic because of this. There will be a reduction in hematocrit value also, and additionally the clotting factors, the fibrinogen is increased. Fibrinogen levels are increased; they are almost doubled, and all the clotting factors are increased except for factor number 11 and factor number 13, sir.
Very good.
Additionally, sir, there can be an reduction in platelet count, again due to hemodilution, and there can be an increase in leukocyte count.
So what about the functionality of blood? What about the gas carrying capacity, oxygen and carbon dioxide?
It depends on the hemoglobin levels, sir, and the partial pressure of oxygen in the arterial blood. In case of in a normal pregnant female, there will be a reduction in oxygen carrying capacity, sir, because of hemodilution.
Okay.
Sanish, the timer has stopped basically. It's okay. Doesn't matter.
I'm manually checking it, sir.
Oh, okay. Okay. You are one step ahead of us, as always. Yeah.
Sorry,
Continue, Vignesh. Continue.
Yes. Sir, vital signs. Other vital signs include blood pressure. In sitting position, blood pressure in the right upper limb was found to be 134 by 78 mmHg, sir.
You are the patient. Who was sitting? You or the patient?
The patient was sitting.
Why? Why did you make the patient sit up?
Sir, she was sitting comfortably in a chair, and I examined the patient in the OPD, sir. So,
can you check the blood pressure when the patient is lying down supine?
sir, I would prefer this particular patient is in her third trimester and in 39 plus 2 weeks of gestation. In this patient, I would not prefer for her to lie down supine, sir. I would instead check her blood pressure in left lateral decubitus position.
Left lateral. Okay, done. Not right lateral.
No, sir.
Any particular reason?
Sir, the inferior vena cava is anatomically placed on the right side of the body. So if I place the patient on the right lateral position, it would still compress the inferior vena cava. The gravity uterus will still compress the inferior.
What are you trying to hint at?
Sir, I am trying to hint at supine hypotension syndrome or aortic.
Okay. When does that happen?
Sir, it happens. It is more evident in the third trimester.
As soon as the organ becomes abdominal, out of the pelvis, when it moves out of the pelvis, grows out of the pelvis, it becomes a reality. Initially, it is only the IVC which is compressed, and later, when the gravid uterus grows in size, obviously, even the aorta can get compressed. That's why you say aorta caval compression, right? You don't just say vena caval compression. Yeah. How many percentage of the patients do you think will have this?
Sir,
it's maybe about 10% and not more. Not every patient will have the supine hypotension syndrome. What do you find if the patient has supine hypotension syndrome?
Sir, if the patient has supine hypotension syndrome, then I would ask, in history taking, I would ask leading questions which could hint at it. For example, in lying down supine position, she might feel giddiness or syncopal episodes that might suggest supine hypotension syndrome, sir.
Yeah, it's only the faint.
Yes, sir.
Anything else?
Sir,
obviously, the blood pressure would fall, right?
The blood pressure would fall, sir. Yes, sir.
Okay. They can't faint. How do you manage this? Okay, anyway, we will come to that later. Yeah. Okay, carry on.
Sir, respiratory rate was 18 per minute, sir.
Okay.
It was, and patient had an effort tolerance of 4, sir.
Just 4.
Yes, sir, just 4, sir. Sir, prior in her first trimester, she had good effort tolerance of greater than 4. But as her pregnancy...
okay, understand. Yeah. Okay, next. Go
on. Airway examination, sir. The patient was moderately built. The right narr is more patent than the left. Mouth opening is 3 centimeters entrance scissor gap with Mallampati grading was 2. The neck movements were unrestricted and painless. With the thyromental distance of about 6.5 centimeters. There are no loose or missing teeth according to as far as dentition is concerned, and there are no dental prostheses, sir. When I examine the spine, the skin...
Actually, does it mean anything to you when you examine the airway, when the patient is comfortable, like this?
Sir, when the patient is comfortable in a patient, when compared to a patient who is in labor, there will be reduced airway changes, sir. Because in a patient who is in labor, might have engorged blood vessels and blood capillaries that can increase the Mallampati grade as well as the airway management.
Exactly. The airway examination now, when the patient is not in labor, may not indicate much to you, and we all know that there is hyperemia and there can be edema, but it only gets worsened when the patient gets into labor, right?
Yes.
And towards the end of second stage, it can be still worse.
Yes.
Yeah. And the airway when, carry on.
And one more thing about airway, that Mallampati grade, that also changes in about more than 30 to 40% of the patients. From 14th week to 38 weeks, Mallampati changes from 2 to even 4. So airway examination just before you give anesthesia for an emergency cesarean section will be more productive than a pre anesthetic evaluation sometime earlier.
Yes.
And even if the patient undergoes C-section, the airway changes continue to happen, and it's quite dynamic. And when you might have been able to intubate the patient easily, but towards the end, when extubation can be tricky because the airway becomes worse than even under C-section, right? Yeah,
Yes.
where the patient does not bear down. All the other changes between initial stages of labor to the second stage of labor, it is because of the straining or the bearing down. But even with the absence of bearing down, the airway changes do occur. Please keep it in mind.
Yes.
Yeah.
Sir, the skin over the spine appears within normal limits.
Yeah, fine.
And the spine
Next.
is non-tender, no gross deformities.
Next.
Sir, coming to systemic examination.
Nothing found there.
Sir, no significant history.
Continue.
Sir, in abdominal examination, I performed the Leopold's maneuvers. For the fundal grip showed a hard round structure, which is ballotable, probably the head. And the lateral grip showed right side showed a smooth curvature, probably the trunk. And the first pelvic grip revealed a soft irregular structure, probably the breech. And
after 30 years in anesthesia, I'm still not convinced whether we are qualified enough to do all the grips, and are we supposed to be doing this? But anyways, you can skip this.
I had an obstetrician with
it's a we'll skip this and go forward.
Sir, to summarize, this is a 29-year-old primigravida in her 39 plus 2 weeks of gestation.
You wrote 39 plus 5 there.
Sir,
I thought your presentation took 3 full days.
No, sir. That was.
Thank God.
I missed. 39 plus 2 weeks of gestation at term with no comorbidities, admitted for elective cesarean section and safe confinements.
What is the ASA grading of this lady?
She's ASA 2, sir. ASA physical status 2 grading, sir.
Okay. Now, as an anesthesiologist, where, when, and where you're called in to manage this case, this patient?
Sir, this particular patient is an elective patient. So, and since the examination suggests to a breech delivery, and the patient is also giving me a history that she's having an abnormal presentation, the baby is having an abnormal presentation, I would probably see her in the elective OT, sir. So, in an elective setup. So,
elective OT, you will see her for
elective cesarean sections.
Okay. Say that the lie was normal. There was nothing abnormal about the lie. And what are the situations where you are called in, and what is your role as an anesthesiologist?
So, since if the lie was normal, then this patient would probably be taken for normal labor first, given a trial of normal labor first. At that point of time, I would be called for pain relief in the form of labor analgesia.
That you can be called in for labor analgesia, and then if at all, you will be called in for an elective C-section or if the patient has any episode of fetal heart rate dipping, you will be called in for emergency C-sections. Your role would be to provide labor analgesia or to provide anesthesia for C-section. All right?
Yes.
Yeah. These patients are generally, a booked case is extensively investigated. But what are the investigations you would like to have?
Sir, in this patient,
Sachin, anything else you would like to ask before we go?
Sir, would proceed into so safe confinement.
Hello, sir. Sir, I'm sorry, sir. I could not
Yeah,
hear
I
you.
think your net was a little unstable, Sachin. Can you just repeat? I didn't make out anything.
Okay, okay.
Yeah.
Was this patient admitted for safe confinement? Is it only because the patient had, this is a primary gravida, so because of breech lie, was it the only reason, or whether there was anything?
Sir, that was the only reason, sir. The breech lie was the only reason, sir.
Yeah, so so the role of anesthetist, like when the patient is confined there, um, 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 will come into play even in obstetric emergencies.
Yes, sir.
I think we'll come to that later, sir.
Yeah, sure. Yeah, carry on. What are the investigations you would like to do?
Sir, in this
Normal
patient,
pregnancy, she may end up with C-section.
sir, in this patient, I would like to get a complete blood count, sir, with hemoglobin, platelet count, and TLCs. And I would also request for a coagulogram study with international normalized ratio. And I would also request for
Any particular reason why would you like clotting time? Sorry, PT and INR?
Sir, if I want to, sir, both the platelet count and the INR and PTA will determine whether I can provide a safe regional anesthesia for this
No,
patient.
I don't think there is any role for PT-INR. Platelets, yes, because platelets, obviously, you know that what happens to the platelet numbers in pregnancy?
There will be a reduction in platelet.
Yeah, but most of them will have more than 1.5 lakhs. Therefore, it should not matter much to you there either. And PT-INR routinely, there is no need. If something is there in the history which suggests that the patient is hypertensive disorders and patient is moving towards HELP syndrome, maybe yes, you need an LFT. But otherwise, I don't think PT-INR is needed. Yep.
Sir, I would request the patient or the obstetrician to share with us the ultrasound report to
Do you
determine.
expect to find any change in?
Sir, expect to find a change in, sir? I couldn't hear the complete.
Yeah, do you expect to find any change in the bleeding time or clotting time?
Sir, I do not expect to find
Okay,
any.
okay. That's even with the increase in twofold increase in fibrinogen and all those clotting factors, you don't expect?
No, sir. The VTCT will remain.
Okay.
Sir, I would request the obstetrician to share with me the latest ultrasound, determine whether the placental position is favorable, sir, and whether the placenta is creta, increta, or percreta.
You expect all this in a primary?
Sir, I do not, but I would like
Percreta.
to
Percreta, ecreta. No, don't dig a grave for yourself. Okay. Yeah. Let the examiners try. You don't. Yes. Yeah, continue.
താങ്കൾ വിളിക്കുന്ന വ്യക്തി ഇപ്പോൾ കോളുകൾ സ്വീകരിക്കുന്നില്ല.
No, it's okay. Those disturbances will be there. Even when you write your exams, even when you do your exams, this kind of disturbance will happen.
Yes, sir.
Because it happens in the hospital, right? Yeah. This is just to prepare you for the exams. Yeah.
Yes. Sir, I would not like another investigation. That would suffice in this patient, sir, because she does not have any comorbidities or.
Good. That's nice. Yep. Yeah, you don't need an ECG, you don't need an echo, you don't need, okay, basically because you know the changes, what can happen in pregnancy. Therefore, you don't need to prove that, right? Yeah, CBC, and then anyways, the obstetricians would do all kinds of investigations. Maybe what you can look at is the charts where the patient has been sequentially investigated, and if there is any deterioration, right? Yeah. Okay. Now this lady you are called in for labor labor analgesia. What are your options? Be quick when you mention about all the methods available to you, and then we'll talk in detail about the gold standard.
Sir, I would go for epidural analgesia in this patient, sir.
What are the options available to you?
Sir, continuous epidural infusion and patient-controlled epidural analgesia.
When you have a long question on labor analgesia, you can't be saying that epidural and epidural only, right? That's a gold standard, I agree. But what are the options available? Sagnik, can you mute the others other than we three?
Sir, I can, sir, inhalational agents can also have also been shown to have analgesic properties in labor.
Okay. Anyways, Sanish's timer says we have got only 8 minutes. Yeah, you have a lot of options. You can use psychological therapies to pharmacological therapy, and read up all of you read up about labor analgesia, because it's a long question for you people in the exams. And as I said, yeah, pharmacological therapy, you have drugs available to you, you have inhalational agents available to you, and then you also have regional anesthesia, analgesia rather, regional analgesia. Regional is again the nerve blocks and the central neuraxial blocks. And it can be spinal analgesics, or it can be epidural analgesia. And the gold standard, as I said, is the labor epidural analgesia. All right, we'll come back to that later. Epidural analgesia. This lady is posted for C-section tomorrow. All right, elective. She has a breech presentation. The rest of the things are normal. You go to do the PA. I know that she's an IT professional, but we'll presume that she's not. And she's in a general bed. And when you go for your PAE, the nurse calls you and says, "Sir, this lady is unresponsive." What do you do?
Sir, first I would check the patient's shoulder and find out if there is any response. I would ask the nurse in between to check her sugar levels. I would check for the pulse. If the patient is
sugar levels,
sir, hypoglycemia in an otherwise.
Okay, no, it's unlikely. We don't talk about hypoglycemia as a cause there. Yeah.
I would check for her carotid pulse, sir. If the carotid pulse is palpable, I would ask for the other existing. But if the carotid pulse is not palpable, I would initiate the I would call for help first and then initiate the CPR. I'll initiate the chest compressions, and then I would also.
How is resuscitation different in a pregnant woman?
Sir, the capillary shift of the diaphragm makes the cardiac mediastinum also shift upwards. So I would give the cardiac compressions a little more capillary in the mid-sternal point. And I would ask for lateral uterine displacement, left side uterine displacement in these patients.
Lateral uterine displacement.
Yes, sir.
Okay. How do you do that, Vignesh?
Sir, if someone from the obstetric team is available, I would ask them to push the gravid uterus towards the left side of the mother, sir.
Okay.
What is the technique? No, you can have an assistant who also does that.
Yes, sir.
The co-PG can do it. A nurse can do it. A technician can do it.
Yes.
It's
in fact, they will be better than the obstetrician.
Yeah, manual uterine displacement. How do you do that?
Sir,
there are two techniques. With one hand or with two hands. Sir, if you have two free hands, you can pull the uterus towards you. If it is one hand, it is pushed away from you, right? Yeah. Then anything else you would like to do if you are alone?
I would
If
I'm-
you're alone, there is nobody to push the uterus.
Sir, I would put the patient in left lateral decubitus position and start.
Left lateral, you can't do the chest compressions, right?
I would put a pillow below her. I would place a wedge
Okay,
pillow
that's
below
an
her.
option. That's an option. Can you tilt the patient herself? Can you give a 15 degrees tilt to the bed itself?
Yes, sir.
Yeah, when you're alone.
Towards the
Make sure that the railings go up so that the patient doesn't roll off.
Yes.
Yeah. Then you start chest compression a little more cephalad because the gravid uterus pushes the mediastinum and the heart also is a little shifted, right? Yeah. Fine. What could be the
Sir,
commonest cause for this unresponsiveness in an otherwise normal lady?
Sir,
It's
supine
supine hypertension, right? Yeah, exactly. That's why a pregnant woman should never lie down in the supine position. She should be on either of the lateral positions. Yeah. Fine. What
Sir,
else?
3 minutes more, sir.
Okay.
Sir, I would ask for the obstetric team to be ready with to perform perimortem cesarean section, sir. I would also call for the neonatologist to be ready to receive the baby. I would proceed with CPR as per ACLS guidelines with injection
Okay.
epinephrine for 2 minutes. 1 milligram every 2 minutes, and if at all defibrillator is available, I would proceed with shock. If the patient is resuscitated, it is.
Can you shock this patient?
Sir, there is no contraindication for
Very good. Yeah, very good.
defibrillation.
Yeah, because the conduit is much away from the fetus, therefore the fetal heart does not get involved at all. Yeah.
And always you can justify the mother comes first.
Yeah. True.
As far as airway is concerned, sir, I would ask the any attender who's available to give 100% oxygen, and if possible, I would secure the airway as soon as possible, sir. If at all, even after 4 to 5 minutes, I am unable to resuscitate,
Secure the airway. Secure the airway.
Sir. Sir, with endotracheal tube or mask ventilation, sir.
Wow. When you try the mask ventilation, do you do something else or you don't?
Sir, Selix maneuver, sir. I will perform a cricoid pressure to
again. It's advocated in certain areas, but the thing is, again, the issue of manpower. Yeah, it's always better to secure the airway with the definitive airway. But definitive airway, can it be supraglottic airway devices or just an endotracheal tube?
Sir, based on availability and expertise, sir, sir, endotracheal tube will be the definitive. I would go for the endotracheal tube, sir.
Can you use a supraglottic airway device?
Sir, there is an increased risk of aspiration, sir. In this patient, I will not go for it, sir.
Second generation?
Sir, then also I will not.
Wow. Second generation supraglottic airway devices can be tried. That's all right. That's not an absolute contraindication. And intubation, obviously, it comes with all the inherent risks associated with that, right? And the trauma is more, and they can be, because of the hyperemia, you may cause bleeding, and the blood in the airway is more difficult than a little bit of regurgitation and aspiration. Okay, anyways, yeah, it's perfectly all right when you say that you would secure the airway with endotracheal tube. Okay, then you get okay, yeah.
Sir,
another few minutes we will wind up. Yeah.
Sir,
perimortem C-section. Yeah.
If it takes more than 4 to 5 minutes to achieve return of spontaneous circulation, sir, I would ask the obstetric team to proceed with perimortem cesarean section, sir.
What is the funda in going in for perimortem C-section?
Sir, the most common cause for this particular is supine hypotension syndrome. So if I eliminate the fetus out of the equation, then
Yeah,
the
it-
mother is fighting
yeah,
only for her.
You're basically offloading the uterus, gravity uterus.
as Sachin has said in the beginning, the mother is more important to you. The womb is more important to you. Therefore, you have to save the mother, right? And getting the fetus out, getting the gravid uterus decompressed gives a better chance for the mother to survive. Your resuscitative efforts will be more effective. That is why you get rid of the fetus. Perimotum section, where does it happen?
Sir, it happens at the bedside, sir.
Very good. The infection?
Sir, when it comes to saving a life, the
Okay,
infection.
good. That's nice. Yeah, it
Just,
happens there.
listen, Vignesh. Have you got any idea what kind of incision they put? Just not
Sir,
related to anesthesia.
sir, classical
Vertical incision. Yeah.
Wow, good. Yes, that's nice.
And that supraglottic airway device that actually comes in the difficult airway pathway, even in obstetric failed intubations. Because a desaturating mother is always worse than a mother that is aspirated.
Yes, understood, sir.
Yeah, you can have complications which you can manage later, but primary goal is to save a life. Okay. Anywhere, even when you talk about routine CPR also, you have to remember this, right? Complications can be managed. If I tell you 1980s, when the first ever guidelines came for resuscitation, American Heart Association guidelines, they said even if you cause just rib fractures, it's all right. We'll manage the complications later. Now only we talk about no complications, primum non nocere. But those days, it was okay with having complications, but then you have to save a life. And when it comes to the mother, it is absolutely the thing, right? And moreover, you should remember that maternal mortality is a notifiable issue, and then you will be grilled. Therefore, try to save the mother, right? Yeah. Now, Sanish, I know we have to discuss about the general anesthesia for C-section. We have to discuss about the spinal anesthesia for C-section, and my favorite epidural analgesia. Yeah, Vignesh, when you say this patient is posted for C-section elective C-section, how do you go about? Why is what's your choice of anesthesia?
Sir, if all the investigations I ordered previously were within normal limits, I would
go otherwise for normal bridge presentation. Yeah, we are discussing normal pregnancy. Yeah.
I would prefer regional anesthesia, sir, with the central neuroactive blockade, with subarachnoid blockade, sir.
Okay. Yeah. Then, how will you prepare yourself? How will you prepare the patient?
Why do you prefer that, Vignesh?
Sir, due to the inherent risks of airway management, I would prefer to avoid that and go only for regional blockade, sir. Additionally, there are advantages to regional blockade with a reduced risk of postpartum hemorrhage when compared to general anesthesia, and reduced risk of pure aspiration, sir.
Why should they aspirate?
Sir, the gravid mother is never an empty stomach, sir. So she's always full stomach. So even in a fully fasted patient, there is a slight chance of aspiration, sir. Additionally, there can be chemical pneumonitis also secondary to acidic secretions in the stomach. So that also I would like to avoid.
What is classically described, the stomach contents? What are they classically described as, even when the patient is fasting?
Sir,
a pH of?
Sir, a pH of less than 2.5 and
volume
of more than 25.
More than 25 ml. Yeah, they are prone to regurgitate because of the loss of the esophagogastric angle and then the sphincter.
Yeah. Diaphragmatic crux will be loosened, and therefore the angle
exactly. They are more prone for regurgitation, and then they aspirate. Who described it first?
Mendelssohn, sir. Mendelssohn.
When?
I'm not sure about the.
Renuka didn't tell you that I'm very particular about the history. Yeah, it is related to our independence, a year before our independence. Okay. The classic paper came in 1946, Mendelssohn's. Okay. What's his full name? Anyway, I'm taxing you too much. It's okay, leave it. Doesn't matter. Mendelssohn syndrome is more than enough for you to. He's Curtis Lester Mendelssohn. Doesn't matter to you. Mendelssohn, how many cases did he describe? Anyway, leave that. Yeah, chemical pneumonitis is a possibility, right? Yeah.
Since the discussion came to Mendelssohn syndrome, sir, how do you know whether the patient has aspirated?
That is to me.
No, sir.
It looks like you're looking at me and asking.
the way my laptop's camera is positioned.
Vignesh.
So if the patient has aspirated, you are taking the patient for, like you have intubated, but then the patient has aspirated. How do you know?
Sir, there is no immediate, other than performing an endotracheal suction. I'm not sure that there is any immediate way that we can. If there are audible changes in auscultatory finding crepitations in the basis or in the right side,
there will be a drop in saturation, right?
Saturation, yes, sir. Desaturation.
There will be a drop in desaturation. There will be crepitations on palpation. There can be bronchospasm. There can be a myriad of symptoms that occurs pertaining to respiratory system.
Yes, sir.
Yeah. Okay, fine. Nice. Yeah, you have to avoid. One of the reasons, you said the general anesthesia will be avoided because of the inherent problems with general anesthesia, right? Yeah, maternal mortality, one of the common causes for maternal mortality, it's about 7th commonest reason is anesthesia. And in anesthesia, the aspiration or the loss of airway are two of the commonest causes. That's why it's not going to be an easy intubation, even if you plan a general anesthesia for your obstetric patients. Therefore, the dictum is whenever you have to give general anesthesia, you have to secure the airway. You always have a qualified assistant or somebody senior to you, right? You alone should not be. It's for all the postgraduates, or the consultants who are in. Never try to attempt intubation all by yourself. Okay, GA, there should always be 2 consultants because it can land you in trouble. And as I told you earlier, even extubation will be tricky. Therefore, don't allow your assistant or your friend to leave immediately after securing the airway, because extubation also can be equally bad. For that, I request you to go through Bhavana Shankar Kodali's paper in 2008. I think in Anesthesia or Anesthesiology, one of the journals. And he had actually put up an image of airway when he was inducing and when the patient was ready for extubation. The airway changes were so much, and extubation also is more difficult than the intubation is. All right.
And Vignesh, do you know which set of surgeries caused more awareness during anesthesia than any other?
Cesareans.
Cesareans under GA.
And which other surgery? Can you abolish the awareness under anesthesia during C-section, if at all you give GA? Can you? No, you can't. You have to tell the patient beforehand and take the consent for that. The other situation is polytrauma, when the patient is hemodynamically unstable. Your induction may not be just like a routine induction, and you have to again explain that to the patient or patient's relatives. Yeah, you have to take consent for awareness under anesthesia when you are inducing for C-section. Right? Yeah, what are the choice of drugs? I asked
Sir,
you, how do you prepare this lady for C-section? What are the pre-medicants from the previous day?
Sir, I would first of all, I would take an informed written consent
Yeah,
for.
that's all. That's all done. That's all done. What are the drugs you
I
take?
would place the patient nilperoral for a period of at least 8 for solid, 6 for soft fluid, soft diet, and 2 hours for clear liquid, sir. And I would provide the patient with either H2 receptor blockers or proton pump inhibitors or
When you are when you are facing the exam, real exam, you just say what you practice. Okay. If you
sir,
use PPIs, you say PPIs, and then you also give metoclopramide.
yes, sir.
If you don't,
Uh,
H2 blocker and ranitidine, I will give 150 milligrams in the night and 150 milligrams in the morning of surgery, and you will top it up with metoclopramide. You need not give it in the night. Morning is more than enough, right? Yeah. Whatever you practice, you say that in the exam. Then what are the choice of drugs?
Sir,
GA. You have to oxygenate. You have to oxygenate because the patient desaturates very fast compared to
very
a normal patient because of the respiratory changes. Okay. Then?
Sir, I would pre-oxygenate the patient adequately.
Done.
First of all, sir, I would attach all. I would take.
Okay,
identify
done. That's all done. What are the choice of drugs?
Sir, I would, since the patient has a high risk of aspirating, I would go for rapid sequence induction, sir.
Of course. Is it RSI or is it modified RSI? Watch your words. Watch your words when you
yes.
say this. Yeah. RSI or modified RSI? What is the difference?
Sir, applying required pressure.
There is RSI.
The fixed dose of drugs are given rapidly in
That is RSI. Even modified RSI. Gentle ventilations is allowed with modified RSIs.
Yes, sir.
Okay, what are the choice of drugs? My question was very specific. You answered the question.
Sir, I would go for I would go for intravenous agents like thiopentone, and
Why not
I would go for. Sir, I have more experience with the thiopentone with obstructive case, sir. That is why I'm using. There is no contraindication.
There is no contraindication. The Puritans don't agree with propofol.
Sir, yes, sir. Zero.
Yeah.
Yes, sir. The hypotension is more profound in propofol when compared to thiopentone.
Yeah, and this is maybe one of the situations where you try to intubate with succinylcholine.
Yes,
because it's an anticipated difficult airway. Sanish is very clear how to stop here. Therefore, no more questions to you. And just to finish this, please remember that there is zero tolerance for hypotension. That's why propofol is out, thiopentone sodium. And then you use maybe succinylcholine, or you can use any other inhalation drug for intubation, rapid intubation. Rocuronium, when you have sugammadex, should not be a contraindication. And then anyways, you start giving a lot of inhalational agents and narcotics only after the extraction of the baby. And that is why till then the patient can have awareness. And as I said, intubation may not be that easy. Be ready with difficult airway management trolley first. And as you are aware, only All India Difficult Airway Association guidelines talk about the difficult airway in pregnancy, and you will be asked about that when you come for your exams. Please read up. Okay.
Yes.
And basically, when you have a normally pregnant lady, or a case of normal pregnancy given to you, the focus is mostly on the physiological changes of pregnancy, cardiovascular and respiratory in particular, and gastrointestinal changes. All the other systems also have a lot of changes, including the CNS and renal system and the liver too. But the focus is more on the first three, and then more we will talk more about the airway changes and how it can be difficult airway, anticipate difficult airway. Then obviously your role as an anesthesiologist is to provide analgesia and anesthesia if the patient comes for C-section. You have to know about labor analgesia in detail. As I said, it's a long question, and know about all the modalities, and then you have to talk in detail about the gold standard, which is epidural, right? There are low income group countries where they try even intrathecal opiates for analgesia, just opiates or local anesthetic, small volume of local anesthetics for analgesia, and you should be aware of that too. And epidural in detail, right? What are the drugs used, and what could be the complications, and how do you manage the PDPH if at all it has to happen. Then coming to anesthesia, we discussed that it has to be the spinal anesthetic, or if not, if there is a contraindication, according to me, the contraindication for spinal anesthetic is coagulopathies and eclamptic woman who has not regained the consciousness. If the GCS is less than 14, then you go ahead with general anesthetic. Otherwise, it's always regional anesthesia and subarachnoid block, right? And subarachnoid block, you should know the volume to give and how to know the higher blocks or even total spinals, which should not happen with the given conditions, but still you should be aware of how to look for. And then you should also look at if the patient has complications. Obviously, that I think I will have another case discussion later with the complicated pregnancy. All right. And oxytocin, you will be asked in detail about the oxytocin when you get into C-sections. And neonatal resuscitation is also a part of C-section. Therefore, if there is a second candidate coming up, maybe they will ask about the neonatal resuscitation. Generally, you won't have that much of time. The other tricky thing is when the patient has been provided labor epidural analgesia, and then you have to convert it into epidural anesthesia for C-sections. And you should be well versed with that if you have higher number of cases in your center. All you have to do is labor analgesia. We talk about intermittent boluses of local anesthetic, then the continuous infusion. There are very many papers where continuous infusions have been proved to be ineffective. Therefore, it's always better that you give maybe 0.1% of bupivacaine, about 10 ml, 8 to 10 ml every hour, and try to turn the patient from one side to the other side so that it spreads equally on both the sides, because the patient will be nursed in the lateral position, right? Yeah. Then conversion is, I will just wind up saying that you will have a few moments with you, and whatever the highly diluted local anesthetic which has been going into the epidural space, you stop that, and then get either xylocaine with adrenaline or bupivacaine. If it is bupivacaine, you add 2 ml of soda bicarb to 20 ml of your bupivacaine vial, or you add 3 ml of soda bicarb to 30 ml of local anesthetic with rather lignocaine with adrenaline, and use that as a bolus. Generally, it acts immediately, and you will have dense blockade. It's easier said than done, but still I have been successful with this kind of conversion. Therefore, should not be a problem. You can also try this. Soda bicarb into the local anesthetic and then use enough volume. Since what has been going in earlier was dilute solution, there should not be much of a problem with the higher block either. Epidural space is quite accommodative. Okay. Yeah. And then as we discussed, resuscitation in pregnancy and with perimotum C-section should be good enough. That's about normal pregnancy, right? Complicated pregnancies we'll have later, discussion later, right? Any doubts, Vignesh, from your side? Vaibhavi can also shoot questions. Sachin, your words of wisdom. Yeah.
You covered everything, sir. Only thing, sometimes normal pregnancy, when you get, there are more number of candidates. Examiners might give you scenarios complicated with mitral stenosis and all those things, which Madhu sir said he'll deal with it later at a later session. And antepartum hemorrhage, amniotic fluid embolism, that scenarios where you will be dragged into resuscitation. So you should be able to tell all the conditions that you may be called for a resuscitation, and identification of the condition and management of specific conditions like amniotic fluid embolism, cardiomyopathy of pregnancy, liver diseases of pregnancy, all those things. Okay. Especially this mitral stenosis during pregnancy is a favorite diversion from for normal pregnancy by most of the examiners.
Yeah. Sanish, shall we go ahead?
Yes.
Yeah.
We'll go into a short
Thank you.
presentation.
Thank you very much, Vignesh, and all the best to you. All the best to you.
Thank you very
We'll
much.
move on. Okay.
Please stay back till the end of the program, and requesting the audience to put in your queries, comments in your chat box. It will reach us. Our panelists will respond to you. Okay, now we'll proceed to the short case session. Over to you, sir.
Yes.
Thank you.
Thank you, Sanish.
You can start, Dr. Vaibhavi.
Yes, sir. Good evening, sir and ma'am. I'm presenting a case of bronchial asthma today. I'm presenting a 28-year-old housewife, resident of Ahmedabad, named Miss Ramila, presented with the chief complaint of the discharge from right ear with deafness of the hearing since 4 months. Patient was apparently all right before 4 months when he started having hearing loss, which was gradual in onset associated with serious type of discharge from right ear. Patient do not have any fever or sore throat. Patient is known case of asthma since 3 years of age, had occasional episodes of wheezing relieved by the medication. Last episode was 2 years ago, controlled by the medication. Patient do not have any history of recent hospital admission. Diabetes, hypertension, epilepsy, or jaundice. Do not have any history of COVID-19 infection. Do not have any history of past surgical history, or do not any history of drug allergy. Patient is controlled bronchial asthma with formoterol and budesonide inhaler 2 puffs twice daily since 5 years, and also take salbutamol inhaler 2 puff SOS. Patient having a mixed diet, normal bowel and bladder habits. Patient is non-alcoholic, non-smoker with no social addictions. No similar complaints found in the family also. During general examination, patient is conscious, cooperative, oriented, time, place, and person. Patient is lean built and nourished. Examination conducted after getting her consent. Patient height was 152 centimeter, weight is 55 kilogram, BMI was 23.8 kilogram per centimeter square per meter square. Patient do not have pallor, icterus, clubbing, cyanosis, lymphadenopathy, edema. Nail was normal and JVP was not raised. Temperature was patient was afebrile. having 92 pulse per minute with a regular rhythm, adequate volume, equal on the both sides, normal character, no vessel wall thickening, no radiofemoral delay, no apex pulse deficit, and all peripheral pulse were fed. BP was 130/96 mmHg in the right brachial artery in sitting position with the sphygmomanometer at the level of the heart, having 18 breaths per minute and thoraco-abdominal type of breathing with 96% SpO2 at the room air. Airway examination was almost normal, patient having a normal airway. During the respiratory system examination on the inspection, patient having respiratory rate of 18 breaths per minute, tracheal on the centers, chest is normal, bilateral chest movements are equal and appear decreased, no visible swelling, venous, prominence, pulsation, accessory muscle of respiration not used. On palpation, all the inspection were confirmed, and a trachea in the midline, chest expansion 2 cm on the full inspiration, AP diameter of the chest was 28.5 cm, transverse diameter 29.5 cm, chest movement was normal bilaterally, and tactile vocal formators was normal bilaterally. On percussion, resonant note here all the areas in the sitting position. On auscultation, bilateral vesicular breath sound heard, while vocal resonance normal, no crepitation or other added sound was found. On the bedside, PFT single breath count was 25, subarachnoid breath holding time was 26 seconds, cuff text negative, V stage was negative, laryngeal height is 6 cm, and forced expiratory time was 4 seconds. Abdominal examination is normal, no any abnormality detected. On the CVS examination was also normal. So
no, actually, when you do a short case in an exam, you are supposed to give only the positive findings. You don't even have to bother about the detail, even if it's a system involved. You are not expected to give all the details. Okay, only the positive findings. Should be over in 2 minutes flat. Okay, yeah.
Okay. So, the 28-year female presented with the serious urea discharge and impaired hearing is posted for right tympanoplasty under evaluation, who is known case of bronchial asthma control on the inhaled formoterol and budesonide medications. Thank you.
What is that? Thank you. You're going to leave with it?
No, sir.
She's posted for
right tympanoplasty, sir.
Tympanoplasty. Okay, she's a known case of bronchial asthma.
Yes.
It's given to you. How will you investigate this lady for the proposed surgery?
Sir, I will ask for the ask for the patient for the investigation like CBC, serum electrolyte, RFT, LFT, chest X-ray in ECG.
Whenever you talk about the investigations, no, every investigation there has to be a significance.
Yes.
And we should talk about the significance of each of these investigation.
Yes.
Yeah.
Sir, CBC. In CBC, there will I will see for the WBC count. It may be increased during if any ongoing infection is going on.
Okay, only that, or are you going to look at a particular blood cell?
Yes, sir. IgG. Eosinophil differential neutrophil.
Yeah, absolutely. Absolute eosinophil count is more important. How much is acceptable?
Sorry, sir.
How much of absolute eosinophil count is acceptable to you?
Sir, there may be one eosinophil is 1 to 4 eosinophil may be present in peripheral smear. If more than that, it is significant.
No, AEC, absolute eosinophil count.
Sorry, sir.
Okay, we'll go on. Yeah, what other investigations? IgE, you said. What are the normal levels?
So, sorry, sir.
No, you said you only said you want the IgE investigations, right? IgE. Is it elevated or is it normal or is it?
It is elevated, sir,
Why should it be?
due to type 1 hypersensitivity reactions.
Okay.
We are above 1000 unit per ounce.
Okay. Fine. Accepted. Then. What other
What is
investigations? Sorry.
Sir,
no, continue, sir. I
Sachin,
was just
continue.
about
No,
I was,
continue.
I was just about to ask that what other investigation the same.
But carry on. What other
Um,
investigations?
sir, I will order a PFT, sir, also.
Okay.
And
You do CBC, IgE, and then a PFT.
yes.
Have you done anything by the bedside when you examine?
Yes, sir. Bedside PFT should be done.
You're done?
Yes.
Did you talk about that when you presented the case?
Yes, sir.
Okay. Yes, I wasn't there. Sorry. Yeah.
One thing I have to. So when you're presenting a case with a respiratory disease, one
Yes.
thing very important is the effort tolerance. What all things the patient can do. Have you heard of Royson's classification?
Royson classification, sir.
Yeah.
There is
You mentioned this patient is fairly controlled bronchial asthma.
Yes.
But I would like to know what all this patient can do, because that will have a lot of implication on the kind of anesthesia I'm planning. So if you can mention some criteria during your presentation as to tell about the severity of his or her respiratory disease, that would be helpful.
Yes, sir. Patient do not have any exertion on the rest, sir, or normal exercise, sir. Patient.
Yeah, that is.
That is grade 0, sir.
Okay.
On exertion, he failed. This exertion is a grade 1, sir.
That's
Hello.
all. You have only 2, grade 1 and
grade 2. Sir, there is a 4 grade is there in Royson classifications. And 4th one is a exertion on at the race also, sir.
Okay. What you advise PFT first, or do you have any other sequence of ordering investigations? Sachin's internet is all troubling you.
My connection is unstable. Like,
yeah, absolutely. Yeah, that's okay. Doesn't matter. Yeah, I was trying to ask her what other investigations before you order PFT.
Okay, sir.
What other investigations?
Sir, we can also do chest X-ray for the patient.
It's not we can also do. You have to do. Just
yes.
Yeah.
Yes.
What are the findings you may get in bronchial asthma?
Since this patient having a bronchial asthma since 3 years of age, chronic asthmatic patient is there. Patient has obstructive lung disease finding like hyperinflated chest field, tubular heart may be there. Tubular heart is there. And hyperinflated lung field will be there, and diaphragm will be more flattened.
That is for COPD. Is it for bronchial asthma?
It is,
sir. What you said just now.
I said the finding is for COPD for my patient having chronic bronchial asthma. So it is also there also.
What is so surprising about the case you presented? How many percentage of childhood asthma become asthma of the adulthood?
Sorry, sir.
Childhood asthma, it is commonly known as it is quite time sensitive. It is restrictive to childhood. It does not continue into the adulthood. But what percentage of patients will have bronchial asthma continuing into the adulthood from childhood?
Sir, it maybe 18 to 20%.
Wow, that is too much. Okay. Anyways,
By the way, what Madhusudan sir was trying to tell you is, see, when you have a case with these kind of symptoms, you should be knowing the differential diagnosis. So it can be bronchial asthma, it can be a left ventricular failure, it can be a tumor sitting somewhere, it can be COPD, so it
Yes.
can be a bronchial stenosis, a lot of things. So it is very unlikely a childhood asthma prolongs for these many years, extend into adulthood. So your investigation should be concentrating on identification and diagnosing identification, like whether it is really bronchial asthma or it is something else, because you don't need surprises in the operation theater when you try to anesthetize this patient.
exactly.
So that was what sir was trying to hint at.
Exactly. Yeah, that's we should be aware of the other causes which might mimic bronchial asthma, right? Yeah.
Yes.
Okay, you do a chest X-ray, and then what else?
We can do, sir, ECG also
For what?
to see if any patient have any right ventricular
Yeah, the
dysfunction.
age is basically against it. Therefore, you need not ask much.
Yes.
In the history, did you ask about the triggers?
Yes, sir.
Okay.
When she is too much emotional, she get such a exacerbation of the dyspnea.
Okay. Anything else? Any allergens?
No, sir. No any allergic history.
When somebody has presented to you with bronchial asthma, let's assume that she has isolated bronchial asthma.
Yes.
What are your anesthetic concerns? What are you worried about when you anesthetize them, especially when you handle the airway?
When sir, if the bronchial asthmatic history is present, the airway will be reactive. During anesthesia, if the airway manipulation occurs, patient may underwent bronchospasm.
Hyperresponsiveness.
Hyperresponsive.
Okay. Right. And
patient may underwent for bronchospasm.
Bronchospasm. Why are you worried about the bronchospasm? What is bronchospasm basically?
It is due to spasm of the small airway of the respiratory tract.
Yeah,
So
basically there is airway narrowing, right?
Yes.
Airway narrowing. What are the causes of airway narrowing?
Airway narrowing is bronchial asthma.
In bronchial asthma, what are the causes of airway narrowing?
Airway due to airway hypertrophy, airway edema.
Okay, good.
Any vagal due to vagal tone, increase in vagal tone or decrease in sympathetic system.
There is smooth muscle contraction.
Yes,
there can be airway edema. There can be airway thickening because there is remodeling of the structures. And then there is mucus hypersecretion. Okay.
Yes.
So is this airway narrowing similar to COPD?
No, sir. In COPD, the airway narrowing will be almost not reversible. The bronchial asthma airway narrowing will be reversible.
Okay. Anything else?
Airway narrowing it is a more disease up to alveoli. In COPD patient, and airway destruction will be there. Whether in asthmatic patient, airway will be almost normal. Only spasm will be there.
Wow. I just told you there can be remodeling, there can be thickening of the airways, there can be hypersecretions. They're not normal. You can't have bronchi which are normal and they still have bronchospasm, right? Yeah. Then how do you treat bronchial asthma? Be brief. Just give me the drugs.
Sir, we can treat bronchial asthma with various medical agents like
Yeah.
short-acting beta agonist,
Hmm.
anticholinergic agent by inhalation. We
Beta
can,
agonists, which are they?
sorry, sir.
Which
Beta,
are the beta
salbutamol, levosalbutamol we can give.
Hmm.
We can also give anticholinergic agent like
How do you give?
we can nebulize that agent or give by MDI,
MDI is what? I don't know.
meter dose inhalers.
Okay, meter dose inhalers. Okay.
Yes.
When you use an MDI,
Yes, sir.
salbutamol or levosalbutamol, when do you think the onset of action happens?
Within 40 to 60 seconds.
Wow, that is super fast. It takes about 5 minutes. Okay, yeah. And can you tell me what are the complications of side effects of salbutamol?
Yes, sir. It may cause tachycardia.
Hmm. And
Hyperparesis.
Wow, what is that?
Sorry, sir.
Tachycardia, I agree. Then the commonest side effects are actually the CNS related. They will have tremors, they will have anxiety,
Tremors, anxiety.
and then the palpitations and tachycardia. Okay.
Yes.
And anything else happens to the potassium levels? Can you use it?
Hypokalemia.
Yeah, that's why inhaled salbutamol can also be used as a drug in hyperkalemia, right?
Yes.
Yeah. There can be hypomagnesemia also. Okay, then what else? Salbutamol.
Levosalbutamol. We can also give anticholinergic agent like tiotropium bromide, ipratropium bromide.
Okay.
By inhalation.
Can they be used in active disease?
No, sir. It can be used for rescue medicine only.
So,
What are mast cell stabilizers?
Luke, Luke, Zafi, Lucas, and Montelukast. Xylutone can be also given.
Okay.
Will you give it during an acute attack?
No, sir. It is only rescue medicine. We cannot give in active attacks. It will take longer to act.
Oh, God. Okay. Thinking about the pathophysiology, what should be our first line of treatment when the patient with bronchospasm is presented?
Sir, we should give 100% oxygen to the patient. And we should also nebulize the patient with the short-acting beta-2 agonist. And we should ventilate manually on the back, sir, so we can know the.
Somebody having bronchospasm will start bag masking the patient. Too much. Do you use corticosteroids as the first line of management?
Sir, we can give corticosteroid, systemic corticosteroid, but it will take at least 4 to 6 hours to work.
Can you use inhaled corticosteroids?
Yes, sir. We can also use inhaled corticosteroid.
Which is better, inhaled or systemic?
Sir, inhaled corticosteroid is better.
Why?
It will reduce the systemic side effect of the systemic steroids.
Okay.
It will also act faster.
Act faster. Yeah. Basically, any drug which acts on the site is always preferred. Therefore, inhaled corticosteroids are the first line of management because that's what I asked you. Thinking about the etiopathogenesis of bronchospasm.
It will reduce.
So, since this is an elective case, that corticosteroid should be started well ahead of the surgery.
Yes.
Okay. Then Any other drugs?
Uh,
Montelukast, you said. Then
yes, sir. We can start,
Silutam, you said.
but not in
Do you use methylxanthine still?
Yes, sir. It is over to the counter. The patient are using it, theophylline and aminophylline. But it is having shorter therapeutic index and much side effects. So we should avoid.
What is the side effect? Which are narrow therapeutic index, I agree. What are the side effects which you are worried about?
Sir, tremors,
Hmm.
hypokalemia, tachycardia.
Theophylline.
Yes, sir. Chest pain will be there.
Right? Then what are you worried about?
Drug interaction also.
Yeah, fatal arrhythmias are what you are
Arrhythmias
worried
also.
about. Yeah, fatal arrhythmias. Okay, that's why aminophylline is almost out of our practice. If at all you use, what should you monitor? You should monitor the serum theophylline.
Potassium.
No, theophylline levels. It's got nothing to do with the potassium. You have to monitor the serum theophylline levels and make sure that it doesn't exceed the acceptable levels. Okay?
Levels. Yes.
Yeah. When you have a patient with, you said you will send the patient for, it's already 8:45. You have to do the PFT also.
Yes.
Said. What is the info you get from the PFT? Do you do it once or do you do it, repeat it?
Sir, repeated PFT should be done that patient is getting control over the disease by the bronchodilator or not to know.
Okay.
We can find the findings of the obstructive lung disease like the picture in the PFT. The FEV1 will be decreased and FVC may be normal or decrease. But FEV1 FVC ratio in obstructive disease will be less than 0.7.
Okay. Yeah.
And FEF 25 to 75% ratio will be also decreased. Total lung capacity will be increased, sir. And FRC will also be increased, sir.
Any other investigations other than the PFT you would like to do? Yeah, don't have much of time. Yeah. Any other investigations? Somebody with bronchial asthma. You've done the chest X-ray, you've done an ECG, you've done the PFT. Anything else?
Serum
ABG becomes a part of the PFT or is it out of PFT?
EBG should be done, sir.
Okay, it's a part of the PFT basically, pulmonary function test, right? You have to do both bedside pulmonary function testing and then finally you have to do a spirometry and then also an ABG if the patient is bad. If the patient's chest is clear and your patient is posted for a tympanoplasty, how does your anesthetic management differ from a routine case?
If a patient chest is bad, we should try to
clear. I said clear.
Then we have to already prior treatment the patient with the bronchodilators with the morning and evening nebulization of the short-acting beta-2 agonist.
Will you give steroid to this patient?
We can give steroid for 5 days. Systemic.
Reference? Systemic steroids for 5 days. Reference?
Sorry, sir.
Right? You only said you would like to give. In the war now, the soldier, when he puts his foot forward, he never retracts.
You have to defend that.
You don't. Basically, you please remember that this is a patient with, well-controlled bronchial asthma. And the patient will get admitted only the previous evening or the morning of surgery, if it can be a day case, right?
Yes.
It's a controlled bronchial asthma. It can be a day case. I don't think you have to admit the patient 5 days prior and then give pump in steroids. It's not needed.
Yes.
The question Sachin has been asking since some time is, when do you supplement steroid to this patient?
If the patient is already on the steroid therapy,
Mm.
and the steroid dose is more than 10 milligram per kg,
Mm.
so we have to supplement the
10
steroid
milligram per kg of prednisolone
prednisone.
or dexamethasone? What?
Prednisone.
Prednisone. 10
Yes.
milligrams per kg of prednisone will be, say if she is 75 kgs, it will be 750 milligrams.
Yes. So we have to give systemic steroid to the patient to avoid high p-axis inhibition.
To give 750 milligrams of prednisolone to your patient, you have to pump in, what is it? It's available as 5 milligrams tablet, right?
Yes, and not per kg dose.
Then you said per kg. Yeah, don't make such mistakes, right? Which can actually kill the patient, and then eventually it will kill you also in the exams. Okay. Yeah. Okay. If the patient has been on more than 10 milligrams of prednisolone per day, you would like
Yes.
to supplement. Then anything else? The patient has a chronic skin disease and patient receives skin ointment. Will you still supplement?
No.
No. It depends on the area and how much steroid the
How much
patient has
steroid?
been applying. Yeah. Then you don't have to. Why are you worried about the steroid supplementation when the patient has been on steroids?
If we don't supplement the steroid, it will be HP-axis suppression to the patient.
Okay.
And adrenal crisis will be there.
Okay.
So
What
we
are the
have
things? What are the things which trigger the axis suppression?
so surgical incision stress.
It's not only the surgical stress, even anesthesia can be stressful. Yeah. Then what else?
Patient may not cope up the.
Yeah, even the sepsis is a stress, right? Yeah. Any stressful situation, you have to supplement. Okay. Then even if everything is normal and the patient had an asthmatic attack, say about 2 weeks ago, and after that the patient has been clean, you still get the agents or the drugs which have been useful bronchodilators for the patient to the OR. Basically, whatever the patient has been responding to, even on-table bronchospasm, if at all he or she has to have, will respond to those bronchodilators. Therefore, you get them to the OR, right? You don't try newer drugs. You use the same old drugs. Then, yeah, when you have a case of bronchial asthma, the thing what you should try to avoid is the interference with the airway, because reactive airway or a hyperresponsive airway, the moment you try manipulating, the patient can end up with severe bronchospasm. With all my experience, I would like to say that the most difficult adverse event I can have on table is a tight bag or severe bronchospasm, silent chest. It's very difficult to manage them on table. All right. Now, if the patient has to have, you are just induced, you gave narcotics, you gave propofol, you induced, you have given, you are also monitoring the bispectral index or entropy, and the patient is acceptably deep. You have given the relaxant, you intubate it,
Yes.
all right? And the patient develops bronchospasm, severe
Yes.
bronchospasm. How will you manage?
Sir, first of all, we will increase the FiO2 and
Okay,
we
good.
will give 100% oxygen to the patient.
Good.
Then we will check that what is the cause of the spasm, or it is really spasm or not. We can manually ventilate the patient to check the lung compliance, how it is. Also, we can start nebulizing the short-acting beta-2 agonist to the patient, and also start auscultating the chest simultaneously. We can auscultate the chest if the air is present in one side and one side is not, then it might be not a bronchospasm, it might be intrabronchial intubation. We should check the circuits also. It may show the picture of bronchospasm also.
Okay, that is that you are trying to give me the differential diagnosis for the tight bag.
Yes.
Okay, when you are on that, then tell me what are the other differential diagnosis for the tight bag.
Sir, it may be due to endobronchial intubation.
Yeah, you said that just now.
Yes.
Then,
Or tube may be kinking, airway tube may be kinking, or airway tube may be lodged with the mucus plug or secretions, or tube may be blocked.
That can be
patient
mechanical. There can be mechanical factors, and then the patient factor.
Yes, patient may develop
kink tube, and all is basically the mechanical issues. You manage them. Then,
yes, patient may have a pneumothorax.
Yeah, good. Yeah. If it is a pneumothorax, how will you manage? On auscultation, there is no air entry on one side, and the bag is tight. The compliance is low.
First of all, we will put a needle to the second rib and allow air to pass. After that, we can go for ICD.
Put a needle into the second rib to aspirate the marrow.
Yeah, no.
Then why do you want to put a needle into the second rib?
To pass the
intercostal space.
Intercostal space.
Is there anything else you can do? Do we still get into the classic second intercostal space, or do you go somewhere else? Okay, once you have managed this, there is nothing else other than the bronchospasm. You conclude that it is bronchospasm. How will you treat? You have increased the FiO2, then you check manually whether the compliance is all right or not. But that's not needed because compliance is always given on your ventilator graphics and ventilator. Basically, you don't have you look at the airway pressures there, and then you look at the compliance. Yeah. Then
we can deepen the plane of the patient.
Okay.
By giving a propofol.
Okay, an additional dose of propofol or increase the inhalational agents. Take the MAC deeper. Then
we can nebulize by nebulize the patient with the short-acting beta agonist.
Yeah, that's what we just discussed. You use whatever inhalational agent, MDIs the patient has been used to. You can use it here.
Yes.
How many puffs do you give?
Sir, if we want to give by puff, we should increase the puff by 8 to more than 8 to 10.
Yeah, 8 to 10 puffs because it can be lost. Basically,
yes.
It is not a controlled environment that it can be lost. Yeah.
Yes.
Then after that,
we can do suction.
Okay, if it is a mucus plug, you can. Then it didn't improve with your MDIs. Would you like to give a shot of steroid? Yes.
Yes.
It takes 4 to 6 hours to start acting, but still it's worth giving a shot of steroids. Then,
if a patient is not getting, patient is still worsening, then I will go and check for the ABGA, sir.
Okay. Then,
if in ABGA, if the acidic pH is there, but the beta 2 agonist won't work in acidic pH, so I will correct it.
Okay. Then, any other bronchodilators you would like to use?
Sir, we can give ketamine also.
Okay.
And also
Which inhalational agent is ideal when the patient has bronchial asthma?
Short-acting beta-2 agonist, salbutamol.
Inhalational agent. Anesthesia is given with salbutamol.
Sorry, halothenis.
Halothane. Do you use halothane still?
No, sir. We can use sevoflurane.
Okay. Des?
No, sir. It has pungent.
The best agent is halothane still. Okay. It's supposed to be a bronchodilator. Sevoflurane is also a bronchodilator, but it's not as effective as halothane is. And desflurane is a strict no-no. Yeah. Then?
Will you give magnesium to this patient?
Yes, sir. We can give magnesium to the patient.
What does it do?
Sir, 2 mg.
2 mg total dose.
50 mg per kg in 20 minutes.
Why over 20 minutes? Is there any other agent you can use? Say there is an acute severe asthma who has come to the emergency department. You are called in to manage. After intubation, the patient is still not ventilating. The absolutely silent chest. You have tried the MDIs. You have done the nebulizations. Still, it's very difficult to ventilate.
We can use epinephrine, sir.
How much?
2 to 5 microgram
per
ml.
Like 2 to 5 micrograms.
How will you give epinephrine?
I think Sanish will kill us now. It's already 8:59. Yeah, basically even epinephrine can be used,
Yes.
but not 2 to 5 micrograms per kg per hour. You are trying to say that, right? What is the dose of epinephrine? That's the last resort anyways, okay? You can, even in the ICU, even in the emergency, you can take an anesthetic machine, anesthesia machine, and try to use an inhalational agent that will work better than any other conventional agents. Ketamine is an option, I agree, okay? When it is still resistant, you can use epinephrine, right? And when you have another 3 minutes, I think, Sachin, you would like to wind up or?
So just to add a few points, sir,
Yeah,
like
sure.
induction strategies to prevent intubating response.
Yeah, good.
So your choice of inhalation agent, use of opioids, lignocaine, that has to be there. And intraoperatively, we covered almost everything, intraoperative bronchospasm. And at the end of surgery, what are your options of extubation? Whether it is deep extubation, if it is deep, how do you do it? Whether you want the patient to be fully awake. And at the time of extubation, also there is risk of bronchospasm. If the patient is still continuing bronchospasm, the patient has to be kept on mechanical ventilator. So your strategies for mechanical ventilation post-operative period. So all these things will be part of the discussion.
Yes,
right.
Sir. Yeah, and when it comes to the airway management, you should, just like with the COPD, where either you try no interference technique or maximal support. Either you don't interfere with the airway. Whatever cases you can do with regional anesthesia, go ahead and plan and do. Don't meddle with the airway at all. If at all you have to intubate the patient or you have to secure the airway, look at non-invasive or less invasive supraglottic airway devices. And then finally, if it is needed, make sure that your patient is deep enough and you support the patient fully when you push in an endotracheal tube. Anytime during the surgery, don't allow the patient to be in the lighter planes because it can trigger another bronchospasm, event of bronchospasm. And as I said in the beginning, managing a bronchospasm on table is much worse than any other adverse event. Therefore, try to avoid that. Right? Yeah. Good presentation.
And if this was not a short case, a long case would entail a lot of other things, including pathophysiology, differences between bronchial asthma, COPD, differentiation between these things pathophysiologically and
the
symptom
difference
wise.
between bronchial asthma and cardiac asthma.
Cardiac
It's a very
asthma,
favorite question, basically. Yeah.
So from history, what are the points? Investigation, what are the points? And all these things. Since it's a short case, we stuck to the basic diagnosis.
And finally, the post-op analgesia, right? Again, post-op pain also can trigger bronchospasm. Therefore, you have to make sure that post-op analgesia is provided well. Okay. Yeah. Thanks, Vaibhavi. Again, thanks, Sachin, for being there. And Sanish, thank you so much. And thanks to the ICA for selecting us as the opening batsman. Anyway, immediately after Rohit Sharma and Shubman Gill both hit centuries, and I think we are proud.
And it has been a privilege, sir, to be with you once again as your student. I learned.
Thank you so much. That's a little. Okay. Thanks so much, Sachin.
Thank you very much, sir. Thank you, Dr. Sachin. It's been a very informative and refreshing session. So we took a challenge to do a long case and a short case together, which I accept that both the discussions may not be complete, but this is what happens in real life. This is what happens in our real exams. So no single exam session, we can comprehensively cover all the topics. Sometimes the topic may take a huge deviation and go to totally different scenario, like from normal pregnancy, it can go to difficult airways. So that's part of our profession and part of our examination system. So it's my proud privilege to thank all the panelists and the participants on behalf of Indian College of Anesthesiologists. I understand that the audience numbers were more, but though we didn't get any audience query, probably they may be having difficulties in punching it through the web page. At the outset, I would like to thank both the examiners. Madhusudan sir has been my mentor. So it's my privilege to thank Dr. Madhusudan Upadya, Dr. Sachin George. We had been together during our post-graduation days in KMC Mangalore. Thank you very much, Dr. Sachin. And I would also like to thank the head of the department, GMCH Chandigarh, and Dr. Manpreet Dawar Singh from GMCH Chandigarh, Dr. Tarliga from BJ Medical College, Ahmedabad, for nominating two good students for today's session. This will be a learning session for them as well as their colleagues who are about to take exams. And of course, those who have finished their exams, it's a refresher opportunity. On behalf of ICA, we would like to extend a certificate of appreciation to both the presenters, postgraduate presenters today, Dr. Vignesh from GMCH Chandigarh and Dr. Vaibhavi from BJ Medical College, Ahmedabad. These certificates will be, e-certificates will be reaching you soon through your email. Next week, we'll have an interesting ICA webinar on anesthesia for robotic surgery. The team headed by Dr. Mukul Chandra Kapoor. So that's it for the time being. On behalf of Indian College of Anesthesiologists, Dr. Jayashree Sood, President ICA, Dr. B. Radhakrishnan, Academic Chairman, Dr. Baljit Singh, CEO of ICA, and Dr. Muralidhar Kanchi, the Dean of ICA. I thank everybody for your cooperation and contribution. And it's me, Sanesh, saying goodbye to you. Goodbye. See you next week, same time. Bye.